moms and dads, a very warm welcome to another episode of Today's Parent. I'm your host, Christine Casina. In today's episode, we are going to talk about blood pressure. One of the most common problems when it comes to pregnancy, a lot of women experience blood pressure issues. In fact, it is said that 10% of women experience blood pressure issues, either low, high. Daktari will share more with you. And in this episode, we are privileged again to have Dr. Kokuti to come and share with us blood pressure matters and what we need to learn. Dr. Kakuti.
Thank you, Christine.
A pleasure to have you.
Thank you.
Pleasure to have you. So today we are focusing on blood pressure. I just want to understand and to make our viewers understand as well, what is the role of blood pressure, during pregnancy and even during birth?
So when a woman becomes pregnant, the physiology of the body changes, the blood pressure changes, the heart rate changes, the work that the heart has to do changes. So normally when you're not pregnant, the heart pumps about 6 liters of blood per minute.
Right.
When you're pregnant, the blood volume changes to accommodate for the coming baby and the pregnancy that is coming on. So all these dynamics may have effect on the mother and the blood pressure.
Right.
And of course, coupled with the risk factors that come with blood pressure, we are not able to know who is going to get high blood pressure. So if any woman who comes to my clinic and is a first mother, I have absolutely no idea whether she's a candidate or is at risk for blood pressure.
Right.
Because those we see on the textbooks as risk factors sometimes are totally off. You expect a beast woman, a woman who is small like you, who is healthy as a horse, and you're expecting her to, she'll never get blood pressure. Boom, she gets it. So it is paramount that every visit that your blood pressure is taken because of the physiological changes that occur during pregnancy.
Right.
Yes.
So then let's talk about what places somebody to be at risk to have blood pressure issues.
Okay, so the risks are very different, but as I've said before, many of the patients we see do not fit in the criteria of those we know.
Your textbook.
The textbook risk factors. So the first one would be, we say normally, is sometimes women who have babies at the extreme of ages.
Right.
So either teen moms, we say less than 18, or above 35. Because above 35, we assume, your body is not that of a younger person.
Over 25-year-old.
Exactly. So your body is not that fit to carry a pregnancy. But many women we've seen above 35 and less than 18 don't actually get high blood pressure in pregnancy. The other one is being overweight, having a BMI of above 38. Another risk factor is if you had a pregnancy where previously you had high blood pressure in pregnancy. If you are already a hypertensive person, so you have what is called essential hypertension, you're normally hypertensive and you're not pregnant, that puts you at risk of getting now what is called superimposed. So you have hypertension, then preeclampsia superimposed on chronic hypertension.
Wow.
Okay? Diabetic patients also, because of the dynamics that occur in the body, they're at risk of getting high blood pressure in pregnancy. The other one, which is interesting, is called grandma theory, but we're not sure about it. It's more in the books than we've seen. So if your husband or your partner's grandmother had high blood pressure, then because he's going to give you his, DNA and whatever.
Somehow.
But those, so the woman is at risk because, the baby's carrying the father's DNA. But those are more of theories. The other one which we know is having a large placenta. And one of the common conditions that gives you a large placenta is a mother who is Rhesus negative. So we have blood groups. You're either positive or negative. So you're either A positive, A negative, B positive, B negative, AB negative, A positive. So those who are negative, if the baby is positive, there's something called isoimmunization. And if that reaction occurs, then what happens is the babies tend to have a condition whereby they have hydrops vitalis, and they may have a large placenta.
Right.
The other one is having multiple gestation. This one is so important. Any pregnancy where you're carrying more than one child, one pregnancy, it's one pregnancy but multiple children.
Right.
So either twins or triplets, quadruplets, that highly puts you at risk. Any condition that where you have hyperplacentation, where you have more than one placenta or a large placenta, puts you at risk. For the baby, we don't know any risk factors for the baby that may give the mother high blood pressure, other than that grandma theory.
Okay.
But most of them stem from the mom.
Okay.
Yes.
So are there different types of blood pressure issues?
Yes, there are.
What are the different types?
So first of all, what is high blood pressure in pregnancy? So when you come to the clinic, there's what we know is normal blood pressure. Now we assume normal for almost average people is 120 to 80. But there are women, we take their blood pressure is 110 over 70. So the higher one is called systolic, the lower one is called diastolic. So it depends. Different people have different pressures, which we usually just, some of them will not take so much consideration into. But if I tell you, I take your blood pressure and it's, let's say, 140 over 90, I'll tell you your pressure is higher than normal. If your systolic is above 140, diastolic above 90. But I will not take that blood pressure at face value and say you have hypertension. Because anytime you meet a doctor, you may be just a little bit apprehensive and anxious, and then I put a machine, and the first thing it does, it tightens your arm, so you may get anxious. So I'll tell you, rest for 4 hours. Then I take your blood pressure at resting phase. And also the type of machine you use may give you wrong readings. The person also the person using the machine. So you must be conversant with taking blood pressure, the different types of machines we use. So after 4 hours, I come and say, Christine, let me take your pressure again. And then I might find actually your pressure is normal. So when I saw you, you might have been anxious. But if it remains high, so it should go above 30 so from your baseline systolic, 30 millimeters above mercury, and the diastolic 15.
Right.
Yes, but that's more technical to doctors. So normally, whatever high blood pressure, whatever pressure is taken, if it's above the normal, repeat it after 4 hours, resting. Give the mother a nice place to rest, and then take the blood pressure. And then you'll see if it's still high. Now, the different types of blood pressure are, so one we have is gestational hypertension. So gestational is, she has high blood pressure in pregnancy, but she's not passing proteins in the urine. So high blood pressure affects kidney function. So ideally, if I pass urine and I give you to test it, there will be no glucose, there'll be no proteins, there should be no pus cells, maybe a few pus cells because of contamination, but there should be no infection. But if I see proteins to a certain level, then I may suspect that you may have now preeclampsia. Gestational, you have high blood pressure on 2 different readings 4 hours apart, but when I take your urine, and urine also must be taken every time. Blood pressure and urine, every time you attend clinic, they must be taken. Because you may have a normal pressure, but you're passing proteins of especially a high amount, and we normally measure. And we may tell you, collect for us urine for 24 hours, then we measure the quantity of protein that you're passing through your kidneys. So you have preeclampsia. Now you have high blood pressure on 2 different readings 4 hours apart, and when I take your urine, I find proteins. Before, it was coupled with either edema. So a woman tells you, my feet are swollen, and they look like elephant's feet. But that has been omitted because many women have swollen feet because of the pressure of the uterus,
and they don't have to do with
the high blood pressure. Then the third type we have is whereby you have a patient who has chronic hypertension prior to pregnancy, then preeclampsia superimposes on that, and normally very difficult to treat. And that's why this particular patient, is important that her physician clears her for pregnancy. It's like, I give you permission to get pregnant. I have changed, because certain drugs they use when they're not pregnant now become teratogenic, meaning they may harm the baby. And the fourth is whereby you have the complications that come with high blood pressure. Renal failure. You can get renal failure. You can get, edema. And the biggest complication we normally fear is you getting what's called eclampsia. So you have high blood pressure in pregnancy, and then you get convulsions, fits, like epileptic fits. And that's why it has to be controlled. It's so important to control it. Absolutely.
Daktari, there's something I need to take you back to where we started our conversation from. The causes of blood pressure. Did we talk about genetical factors? Is it something that we mentioned? Because you did mention, for example, another one, that you are as healthy as a horse, but still, this is something that then happens to you.
So yes, true. Thank you for reminding me. If you do have chronic hypertension, may have a familial genetic predisposition. That could put you at high risk of having hypertension in pregnancy. In very few cases, it's still not very cast in stone in research that if your mother had hypertension,
you're automatically going to get
Same thing with cancer
as well.
You had breast cancer, puts you at, you'll get breast cancer. It puts you at risk, but doesn't mean you're going to get it. And I like what you've said is that there's some people who are very healthy, and we wonder why they get high blood pressure in pregnancy. You're right.
You have mentioned that some of the effects of blood pressure issues, especially, in a mom or on the mom, kidney issues. You mentioned about edema. But now I'm wondering, when it comes to the unborn baby, what's the effect of blood pressure or high blood pressure or low blood pressure on the unborn baby?
Thank you, Christine, for your question. So the complications that arise from preeclampsia or hypertension in pregnancy affect both the baby and the mom.
Right.
So we'll discuss the ones that affect the baby first. So remember, the pathophysiology of high blood pressure in pregnancy is the vessels, this vasoconstriction. So vasoconstriction is the constriction of the vessels.
Right.
So the pressure within those vessels is going to become higher. You know, if you take a water pipe and I'm pouring water like this, compared to when I press it, the pressure is going to change.
Right.
The same thing with the vessels. And that will affect the mother's dynamics in the circulatory system as well as the baby.
Okay.
So what happens, one of the most common complications we get is Iugr, intrauterine growth restriction. So when the baby is in the mother's abdomen, there is a rate at which they grow. You know, when you come for the scan, I'll tell you your baby is growing well. This is different from small for gestation. Small for gestation is a baby who, for example, at 20 weeks, we expect a baby to be around 1 kilo. But then the scan tells me, based on her earlier scan, her dates are correct, but the scan is saying the baby is 800 grams. But the baby is normal.
Yeah.
So we're like, is this baby small because of genetics? Now, Iugr is different, intrauterine growth restriction. So there's something restricting the baby from growing, and it could either be high blood pressure or other complications.
Okay.
So high blood pressure, with that vasoconstriction, the dynamics of the circulatory system and how the baby is receiving blood and nutrients is affected. So what the person who's doing the ultrasound will tell you, I'm measuring the circumference of the head versus the circumference of the abdomen. If a baby is deprived of nutrition, the place that will actually, can I say, slim down for the baby is the abdomen.
Oh, wow.
Because there's a certain ratio we expect between the baby's head to the abdomen to the
head.
Yes. So if that changes, so they tell you the head looks normal, but the circumference of the abdomen, that ratio is not adding up, then you suspect Iugr.
Interesting.
And normally that becomes a very detrimental. So you wonder, do I deliver the baby or not? The other thing is the person doing the scan can tell you that the blood pressure of the mother is not well controlled, and so it affects the baby, and so the baby's circulation is affected. And the scan person may tell you the baby is fine, but the flow of blood in the umbilicus is abnormal, and so they label that this baby is in fetal distress in utero, but the mother is not in labor. But the blood pressure has affected the baby. And
so of course, the baby goes into distress.
The baby goes into distress. So of course, and one thing we keep telling the mother is monitor how your baby is playing. It's not a joke. So if that changes, either the baby is hyperactive. Like one time I had a patient tell me, I feel like there's a storm. Like my baby's playing too much. And all of us were like, yeah, but that's okay.
That's a good thing.
The scan guy tells me, go and remove that baby right now. That mother had high blood pressure in pregnancy. Wow. Yet another mother will tell you my baby is not playing because the baby has been severely affected by the high blood pressure. The other complication, which normally is the saddest and just one of those things you do not want to encounter in your profession or with a mother, is having what we call IUFD, intrauterine fetal death. And this sometimes is very unpredictable. Most of the time, you can't predict when, if you're following a mother, you're monitoring her blood pressure, it's controlled, and you're following up with scans. And this is where now you find yourself doing very many scans for a patient. Because sometimes if the baby has some slight fetal jeopardy or some distress, some of them you can push a bit and say, the baby's in a little trouble, but let's push. So you find me telling a patient, I need scans every week. So if she's having a complicated pregnancy, that's when it happens. So you have to monitor and make sure that you do not reach that place whereby the baby dies. There are unfortunate cases whereby it happens suddenly and unpredictably. And that for us is one of the most heart-wrenching and even for gynecologists. You never get used to it. This is a life you've lost. So you have to make sure you're keen and have the discussion seriously with your patient. You know, patients come to me and I'm more of an extrovert and I'm very outgoing and laughing. But when it comes to discussing complications for certain conditions, you really don't want to take them lightly. And the mother should be very well educated. If you can give her a brochure, websites she can read, and then empower her to ask you questions about the condition as well.
All right, Dr. Ari, let's take a short break and then we continue our conversation when we come back. Our conversation today is with Dr. Kakuti, and we are speaking about the complications when it comes to blood pressure. We are going to take a short break and we'll be back right after this. Welcome back to this episode of Today's Parent, where we are talking about blood pressure issues in matters pregnancy. I hope you've learned something so far, and we are going to continue our conversation with you, Dr. Kakuti.
Thank you, Christine.
Let's talk about diagnosis. How is blood pressure? I don't know if we focus on high blood pressure, because I remember I was diagnosed with low blood pressure. So let's talk about high blood pressure, which I think is more common. How do you diagnose high blood pressure during pregnancy?
As I mentioned before, is a patient comes to you and they have a baseline. So most people, we expect normal blood pressure somewhere between 120,
Right.
80, meaning systolic versus diastolic. And then others have 110, 170, but it keeps changing. Like now they have, I think the new studies have actually changed and said that someone who has blood pressure of 130, 80 is actually considered to have high blood pressure. Yet for us guys, we're like, that's not very high to do anything about it. Pregnancy is different. So if you have a particular, especially if you have a patient who has records of her high blood pressure, then when she comes, you take a high blood pressure. So we normally say anything above 140 systolic over 90 is abnormal, is considered to be high. But repeat it again after 4 hours,
Right.
because she may be anxious the first time you took it. So any increase in pressure from a baseline of above 30 millimeters mercury and above 50 millimeters mercury diastolic, systolic, then you consider the patient may have high blood pressure. But remember, when you see them at first time and it's high, then repeat it again after 4 hours after she's rested a bit. Because the
Right.
first time you're taking blood pressure, she may just be slightly anxious, so it may just shoot up or something like that.
Okay.
Yeah.
Dr. Kakuti, we've spoken about diagnosis of blood pressure issues during pregnancy. How about treatment? Which reminds me, by the way, there's a question that has come in from June. We have a lot of questions, especially these two questions I want us to focus on. June's question is it possible for her to have a safe delivery now that she has high blood pressure?
Absolutely, it is possible. So remember, when you have high blood pressure, you must control the mother's state, the baby's state, okay, and prevent preeclampsia. So if she's to have a normal delivery, is most likely the baby is fine. She's carried the baby to whatever gestation that needs to be carried to. Remember, there's a high possibility of this baby's complicating, or the mother's blood pressure not be able to control. And so they can be delivered at any time. That's what June needs to be very aware of that. There is no guarantee.
Okay.
Unlike previously when we spoke about a patient asking you, can you guarantee me a normal delivery? No. So if you have high blood pressure in pregnancy, can you guarantee me that I'll carry my baby to 40 weeks? No.
No.
If any complication arises, I can deliver your baby from as early as even 24 weeks.
That is early.
That is very early, because that baby is going to be 500 grams. So if there's any complication, either you're unable to control the mother's high blood pressure, the baby goes into some form of distress,
Right.
or the mother gets eclampsia, that baby must come out. Because remember again, and from the previous show we did, the mother comes first.
Absolutely.
Mother comes
We
first.
did mention
So
that.
there is a possibility for June, and we do hope that June is able to carry her pregnancy up to term. We try not to cross 38 weeks, because the placenta becomes it starts misbehaving, so to speak, in layman's terms. But there's a possibility she can have a normal delivery and a healthy pregnancy despite having high blood pressure, as long as all parameters are in control. The scans are showing the baby is normal. Now, the other thing the mother has to be done for if they have high blood pressure in pregnancy is monitoring of the liver and the kidneys and the blood.
How is that done?
So they have to be taken blood. High blood pressure can lead to complications like HELP syndrome, renal failure. The mother can get fits. So fits, maybe she gets, basically what you call like cerebral edema.
Like she gets puffy.
Yes. So if you find...
Or swollen.
Yes. So if you find, now if your feet are swollen, I'm up and about, so my feet can swell even if I'm not pregnant. Or I take a long flight, my feet can swell. Now, if, for example, I'm somewhere working and I realize I can't take out my ring, your rings have become tight. I remember a patient who unfortunately had to cut off her wedding ring, because now that is you get swelling which is non-dependent. So when I'm up on my feet, dependency, gravity. But if I wake up in the morning and my face is like swollen, my hands are swollen, I'd worry about high blood pressure in pregnancy. So you can't guarantee them that they will reach term, but we try and push them up to term. But we can guarantee that, if the baby, if there's any signs of danger to you or to the baby. So for the mother, one thing we look for is make sure the platelet count is normal. So if I cut you here, Christine, you're going to bleed, but there's going to be a clot that's formed within a few minutes. That means we call that bleeding time. So if platelets are low, that means you're just going to keep bleeding. And high blood pressure affects platelet count. And that is so dangerous. So imagine a patient who has low platelet count has a complication, high blood pressure in pregnancy. You have to take a 4CS for the baby. You have to be, your team has to be on top of things. The other complication is renal failure. So your kidneys can fail. Many patients, the kidneys are failed because of high blood pressure and need dialysis. Most of the time, 90% it will resolve and they're back to their normal activities. The other complication is HELLP syndrome. So all of a sudden you look at your mother and you're like, her eyes are yellow. So it means the liver has been compromised. So if you follow all that, if all that is controlled and it's okay, then you can push this mother as much as you can. If you cannot control her blood pressure, if you cannot, if any one of her blood readings shows there's abnormalities in the kidney function test, the liver function test, the platelets, if the scan shows you the baby is in trouble or the mother gets eclampsia, that baby must be born, regardless of gestation. And those are some of the difficult situations you have to discuss with your mother, because the important thing she's going to ask you is, if you're delivering my baby at 28 weeks, Dr. Kakuti, will my baby survive?
Absolutely.
And
I would be
answer
worried.
is,
Any
I don't
mother will be
know.
concerned.
Yes. And you see, survival will depend on the facility you are in. So if I'm in Narok County or a government hospital, I'm not sure about the ICU facilities for the neonate. Remember, neonatal ICU and adult are different.
It's very different.
And you need a totally different specialist here and a totally different specialist here. So it depends. So if you're in a hospital like Aga Khan and Pisha, Mata, Nairobi, Coptic, those are different levels. I can tell her, your baby's going to be 1 kilo. We are almost good here. Half a kilo. My cousin was born 500 grams at Aga Khan because the mother had high blood pressure. And the mother actually, hers was so complicated that she convulsed. So even her delivery, she was not even aware she's been delivered, And so also the other thing about, should you have a cesarean section, is a cesarean section may depend on the size of the baby. If a baby is a preemie, less than 34 weeks, it is tricky to put that baby through labor. Remember, the brain is not yet, the brain and the covering of the brain are not very well developed. So the baby can, during labor, pass through the mother's birth canal, but injuries can have the baby have small hemorrhages and lead to cerebral palsy.
That will be terrible.
Yes, but there is hope. If she is following up on her clinics, there is hope she can have a normal delivery, a healthy baby without any issues.
All right, Dr. Ari. And, just speaking about what we can do from, going for our clinic visits, as we're winding up, how can we prevent in any way blood pressure issues during pregnancy?
So remember, with every first-time mother, any mother who comes to me for the first time, she'll tell me, I've read about high blood pressure in pregnancy. Am I a candidate? So based on the risk factors we know from the textbooks, I can tell her, if you're obese, above 35 kilos, you have a family history and all the other risk factors, there's a possibility. But doesn't mean she's going to get it.
But it's automatic.
Yes, that's automatic. So, but if a mother comes to me second time, third time, fourth time mother, I'll always ask, did you have high blood pressure in your previous pregnancy? And we prefer that we see you before you conceive if you knew you had high blood pressure in your previous pregnancy.
You have emphasized on that.
Stressed on that. So that, because research has shown there are certain supplements a woman can be put on to prevent high blood pressure in pregnancy. And many who had high blood pressure in their first pregnancy, they've had 3, 4, 5, 2 babies and 0 issues in their high blood pressure. They didn't get high blood pressure because they saw their doctors. So some of them, we put them on aspirin. So aspirin and calcium are 2 drugs that have been scientifically proven to prevent, because now aspirin is an anti-inflammatory drug. So it's also a painkiller. So you want to prevent the inflammation in the vessels in the placenta so they don't constrict and also not form clots. Calcium improves circulation within the vessels. So some women, and they should start this before pregnancy or as soon as possible, especially in the first trimester. Because high blood pressure in pregnancy, I forgot the definition, is it occurs after 20 weeks. Wow. That is specific. Any high blood pressure in pregnancy is high blood pressure in pregnancies, can be preeclampsia or whatever. Okay. But if you have high blood pressure before we see you, then it is essential hypertension.
Which leads me to this question from Emma, and her question is, now that it has happened that I am pregnant, how can I manage if I have blood pressure issues during pregnancy? How can I manage my blood pressure at home, if at all? Is it possible?
So one thing we do is depending on the level of high blood pressure. So you either have mild preeclampsia or severe. There's no moderate. If you have severe, it means your blood pressure, the systolic is above 160, the diastolic is 110. Do not argue with your doctor. You will be admitted. Now, if you come to me with mild preeclampsia, blood pressure is above 140/90, but it's less than 160/110, then I can actually say, can I put you on medication? Let's start you on medication, which you can take at home. I don't need to admit you. But this patient must be somebody you trust for close follow-up. And there's nothing wrong with telling your patient, give me your phone number every alternate day. Go to the nearest chemist, nearest hospital or dispensary. Have them take your blood pressure, send me on phone to tell you whether we're doing something and it's working, the medication giving you is working or not. If you have severe hypertension above 160, diastolic above 110, you will require admission to control that blood pressure because that is very high.
Okay.
Yes.
Okay. Daktari, you are parting short as we wind up today's episode on blood pressure, in pregnancy. What can you tell our viewers?
So one thing I want to tell our viewers is high blood pressure in pregnancy is unfortunately unpredictable. We're not able to tell who is going to get it, who is not going to get it, even despite having the risk factors or not having them. As Christine, you've said, someone can be as healthy as a horse and still get high blood pressure and pregnant. The thing is, be vigilant about how you're monitored. Follow the instructions you're given by the doctor. Taking medication every day, if I have to give you a tablet to take every 12 hours, it is very irritating till the end of your pregnancy. But listen to the instructions, because at the end of the day, I want that mom and that baby to leave my hospital healthy.
Wonderful.
Wonderful.
Wonderful. That's
Thank
a
you.
wonderful way to end our show today.
Thank you.
On a high note, on a positive note.
Thank you, Christine.
Thank you so much, Dr. Kakuti. On top of what Dr. Kakuti has said, remember, if you're pregnant, ensure that your blood pressure is taken every time you go for your antenatal. I hope you've learned something from today's episode, and if you have any other question, send them to 22999 on our SMS number, and we'll see how to cover them in another episode. I have been your host, Christine Kasina, and this has been today's Parent. If you're looking for more information on matters parenting, go to www.supermamas.co.ke, and we thank our hosts here, Little Cribs. If you're looking for kids furniture, make sure you Google Little Cribs. You'll be amazed at what you will find. I do wish you a wonderful day. Thank you so much for tuning in.